Thank you. The next talk is on the renoprotective effects of SGLT2 inhibitors, to be given by Professor Christoph Wanner, who's the Chief of Nephrology in Würzburg. It's very good to see you here, Christoph. Christoph and I would typically have met in the past 2-3 times a year, maybe more. Haven't seen him for at least 2.5 years, perhaps more. So it's a great pleasure to have him here. Christoph is the ideal person to talk about this. He really sort of, I suppose, got into the cardio-renal field in a big way via lipids. He was a lead author and investigator on the 4D study, looking at intensive lipid lowering in the end-stage renal population, and crucially showed no benefit in that group, really putting a cat among the pigeons and emphasizing that the renal population is different and potentially much more difficult to handle than the non-renal population. Since then, he's really had a continuing stellar career, heavily engaged now with the whole SGLT2 inhibitor programs, and lead investigator on some big studies. He's also the current president of the European Renal Association. It's a great pleasure to have you here, Christoph. Thank you.
Thank you, very kind of you, distinguished faculty. It's really a pleasure to be here. My colleague Nico Marx, I think, faded away. I could say it was a smooth traveling to London, so no problem from Germany. And after such a long time to speak here, so ex cathedra, is really a pleasure. In fact, I was there from the first day with EMPA-REG outcome, and we felt it cannot be true. And meanwhile, it's true, and there are some fabulous effects also on the kidney. So here first is my disclosure, the transparency declaration with similar companies in bold, working in the diabetes field, and others in rare diseases where I have some research interest. So actually today, after the heart failure trials, which are on the right bottom, and we have heard about them, we are going now to the left side, to the kidney trials. On top are the cardiovascular outcome trials, and it really is important for the kidney, whether the kidney is a secondary endpoint in heart failure trials or in cardiovascular outcome trials, or the kidney is in the primary endpoint. This is important because only when you get a signal from the primary endpoint, the regulators will give you a label. So we have here now trials in the kidney space for canagliflozin, dapagliflozin, empagliflozin, and you will see it looks quite consistent, and meanwhile we use the word class effect. And EMPA kidney is still running. There are 1,000 patients in the UK in the EMPA kidney trial, and this trial is organized by the Clinical Trial Service Unit in Oxford. So here are 3 major trials we have today. Actually, we have these 70 to 100,000 patients in all these randomized trials, and I don't think that we will see a surprise anymore in the next couple of years with so many patients in a half of 5 years in so many trials with outcome trials. So here on the left-hand side, you have credence only in diabetes, type 2 diabetes patients with the outcome diabetic kidney disease. 4,000 patients, a certain range of glomerular filtration rate were included, 30 to 90, and with a urinary albumin creatinine ratio, so-called macroalbuminuria, above 300 milligram per gram. The primary endpoint was end-stage kidney disease, a doubling of serum creatinine, and renal or cardiovascular death, solid endpoints accepted by regulators. And we also talk about, or actually we only talk about DAPA-CKD in proteinuric chronic kidney disease patients, diabetic and non-diabetic patients, and this trial has given a label to Europe and the world, and today the label is treating chronic kidney disease. Yeah? There's a very broad label, which in the moment comes as a shock to nephrology because it suggests to treat all patients with chronic kidney disease, and I will talk about this. So you see that the eGFR range is now opening up. We see that the SGLT2 inhibitors also work in lower ranges of kidney function, DAPA-CKD, GFR25, still albuminuric, and the EMPA kidney now is a special study in chronic kidney disease, type 2 diabetes and non-type 2 diabetes, going down to a range of eGFR of 20, as Emperor Preserved and Emperor Reduced already has chosen as a lower range of eGFR, but also in patients with no albuminuria. And today are very many elderly with low kidney function, no albuminuria, sitting more or less at home, not fast progressing, and we also study these patients in these trials. And here is actually the main message, the totality of evidence, all the trials with a kidney outcome, 50% decline in kidney function or 40% in some trials, and end-stage kidney disease. In brown or above are those trials with no diabetes patients. We have heard the DAPA-HF and Emperor Reduced, and there is also a DAPA-CKD study, and below patients with diabetes. And you can see the point estimates. They all are left of unity. In part, the confidence intervals do not cross the unity, and the point estimates for me look quite consistent, and the subtotal or overall evidence is a 40 to 50% relative risk reduction. This was so surprising to us because ACE inhibitors and ARBs in patients with chronic kidney disease avoiding dialysis, they cause a relative risk reduction of about 20%, 16 to 20, and the SGLT2 inhibitors appear to have twice as effective. Yeah. This is a result after 20 years in nephrology having only ACE inhibitors and ARBs to prevent progression of kidney disease towards dialysis. And now we have this totality of evidence in front of us. These are the kidney trials actually, and EMPA kidney is coming next year. So this is my only Kaplan-Meier survival curve, the DAPA-CKD trial, and the primary composite outcome was a sustained more than 50% decline of eGFR end-stage kidney disease, which is dialysis, and renal. Those who did not want to start dialysis, a few only, were called renal death. Again, the number needed to treat is 19. This is consistent in all these trials. You see the number of events in the placebo and DAPA treated patients to get a feeling how many events were reduced, and you see the relative risk reduction and the p-value. There are some secondary outcomes which are very surprising for us nephrologists. Renal specific outcomes according to underlying cause of kidney disease. So this is a secondary, a renal specific outcome. You see the overall effect that's without cardiovascular death. Only GFR decline in end-stage kidney disease. You see the 44% relative risk reduction in the first line. Then specifically the diabetic kidney disease, diabetic nephropathy patients. And then there are these elderly with ischemic hypertensive nephropathy. You see the number of patients, not so many, 600. The outcomes are a few. Anyway, the point estimates are left of unity, and then we have the glomerulonephritis. We usually treat them with steroids and immunosuppressive treatment, which cause side effects, and now we have a drug in hands which moves the point estimate to the left, and many among them are IgA nephropathy, the most often seen glomerulonephritis in people, a few only. EMPA kidney has 800 of these IgA nephropathy, just to tell you where we are moving and what our hopes are that we get some better treatment than immunosuppression. And here you see the characteristics of the underlying populations, the proportion of patients with an eGFR below 60 ml per minute and a urinary albumin creatinine ratio in the morning spot urine above 300 milligram per gram, which is macroalbuminuria. On the left-hand side, in the cardiovascular outcome trials, there was a limited proportion of people with an eGFR below 60 in EMPA-REG outcome canvas declare, and only a few with high albuminuria. The renal outcome trials are enriched with people with eGFR, lower eGFR ranges, and the eGFR was 56, so I always talk to my patients as you have 50% kidney function, and then they understand me. Yeah? And the DAPA-CKD trial had 43 mils per minute GFR, 40% kidney function, and the EMPA kidney will have 35 ml per minute. So complementary trials which we have in hands soon or already have. And a lot of people with albuminuria, UACR around 1 gram per gram. These are the different underlying population which sometimes also influence the endpoint, but they were pretty consistent, what we saw. So SGLT2 inhibitors in the moment discussed for everybody with CKD, because we got the label from the authorities, from the EMA and in the US, so we must clearly say yes. And nephrologists are really in the moment a bit nervous, because when you tell somebody, a doctor, a drinking water hypothesis, yeah, then the doctors become nervous. They say it cannot be true. Yeah? Why should we give now everybody with CKD and SGLT2 inhibitor? Or they ask who not to treat usually. So individuals with polycystic kidney disease and lupus nephritis were excluded in all trials because trialists felt that may not have an impact or influence these specific diseases, genetic, inherited. Yeah? We have no recommendation so far for type 1 diabetes and will not get one. There's a higher risk in those patients, and centers start to treat heart transplant patients or kidney transplant patients on a low rate. It works in those kidneys, but maybe the side effects are higher. We have no large numbers in trials. Other rare forms of inherited kidney diseases were included in the DAPA-CKD and EMPA kidney, most likely with no low numbers. And what about those with amyloidosis or Fabry disease? Are they really responding? Are the questions? And there is still a discussion around sarcopenia, low body mass index, mainly coming from Asia, and frailty. Should we treat these patients? And yes, for the elderly in the moment, there are significant numbers above 75 years of age. Urinary tract infections are not influenced. It's the genital infection, needs to be distinguished. Also, those on loop diuretics will benefit, and it should be added on top, or was added always on top of ACE and ARBs. So how does it work? Why is it so good? And in diabetes and chronic kidney disease and in heart failure, a reduction in renal blood flow usually is compensated by the kidney by hyperfiltration. And the hyperfiltration causes injury. On the left-hand side, you have a normal kidney with normal renal blood flow. The vas efferents, blood comes into one glomerulus, the capillary network, it flows out. But when you have diabetes or CKD, you have an activation of the renin-angiotensin system, you have a reabsorption of sodium, and the kidney opens up the vas afferents and tells the body to increase the flow, or the kidney to increase the flow. And increasing of flow goes along with increasing of pressure in the glomerulus, and this damages the glomerulus over time. And I already started, I think, all starts in the kidney, and Nico Marx, as a cardiologist, acknowledged now the kidney and starts to learn function about the kidney. And here is the renal mode of action in those with diabetes and diabetes. It is usually increased sodium reabsorption, also in heart failure patient. And here at the proximal tubule of a glomerulus, and we have 1 million on the left kidney and 1 million on the right kidney, so 2 million glomeruli and nephrons, and you block here at the proximal tubule, the sodium and the chloride and the glucose marches towards the macula densa, and then the macula densa sends a signal to the vas afferens via adenosine. The vas afferens constricts, the flow declines, the pressure in the glomerular declines, and this is the tubular glomerular feedback, the mechanism which protects the kidney. Also, when you have here less sodium reabsorption, the kidney uses less energy, ATP, and this brings the kidney in a much better energy balance when you block here this transporter. So actually it happens, this mechanism in chronic kidney disease, massive obesity, many forms of hypertension, we have heard heart failure and type 2 diabetes. So when you lower the pressure here in the kidney, intraglomerular pressure, then you have a drop in glomerular filtration rate. And these are the data from the EMPA-REG outcome. Here they started this 7,000 people with a GFR of 75% well-preserved kidney function. You have this decline, but then the GFR is stabilizing over time. The placebo group progresses with 2 ml per minute per year. But when you stop at the end of the trial, the intervention, and you bring the patients back 4 weeks later, then GFR jumps back to baseline and you get back everything what you pay at the beginning. This is the intraglomerular hemodynamic effect. Yeah? And actually, this is the delta, translates into heart renal outcome, and this is the type of protection. So this needs to be understood, and if somebody is seeing an increase in creatinine and declining glomerular filtration rate, many are concerned. Yeah? The concerns about this initial decline in eGFR, it is considered largely hemodynamic and reversible, but this initial eGFR dip has raised concerns in clinical practice, and as it may predispose to acute kidney injury. So we have investigated this in the EMPA-REG outcome trial. I'm talking mainly on empagliflozin, but as I told you, it's a class effect. We have seen this dip in every SGLT2 inhibitor. So these are my data, therefore I'm a bit more on empagliflozin. The characterization and implication of this initial dip of glomerular filtration rate was explained in this paper. So actually you have this shift towards more dipping. 28% are dippers, which decline with glomerular filtration rate 10 to 30%. And 30% decline, this you will see in daily clinical practice. Also, placebo are a certain percentage, which are dippers, interestingly. This is the imprecision of the estimation or measurement. So there are a few participants experiencing more than eGFR decline. There were about 70 out of 7,000, a little bit more, with empagliflozin, also with placebo. If you are living in London and you treat with so many people here in London, thousands of diabetics now, you will see this in hospital. Yeah? And the question is it something of concern or not? If you look at those who dip most, those 30%, 10 to 30% decline, you see they stabilize. And meanwhile, we haven't seen acute kidney injuries, and there is a consensus out, especially with cardiologists in a moment, that we should not measure glomerular filtration rate 2 weeks after starting the treatment. Yeah? That's critical, can be discussed, but it makes also with general practitioner treatment more smooth, and nephrologists like to measure Yeah? After they introduced the ACE inhibitor, we measured potassium and creatinine. Now this comes back to us, but on another level of awareness. So maybe not measuring it all. If you look, let's go to the next one. If you look at the 4 large SGLT2 inhibitor trials in type 2 diabetes evaluated for acute kidney injury, EMPA-REG, CANVAS, DECLARE, and the kidney trial Credence, point estimates for acute kidney injury are left of unity, and even SGLT2 inhibitors are better off, and they prevent acute kidney injury and not cause it. So that's very important. Then finally, or one more issue on the mediators, and Professor Marks already alluded to the mechanism and the treatment effects. So in a post-hoc analysis, mediators of the treatment effect of pooled empagliflozin versus placebo were investigated in the kidney outcome trials. So the first sustained eGFR, more than 40% decline was chosen, initiation of dialysis, and 17 factors across different physiologic categories were assessed. So what can you tease out? What factors of a large outcome trial? We measured glycemia, so we took these fasting plasma glucose as glycemic, vascular tone is blood pressure, lipids is a profile and free fatty acid, the kidney is urinary albumin-creatinine ratio, adiposity can be weight, volume status, that's a surrogate for it, or albumin and others. There are 2 models, time-dependent Cox regression over the entire period, or a landmark week 12 baseline to week 12 analysis to get a feeling about the impact. And you see in bold those who had the most impact, and hematocrit came out and hemoglobin quite significant. But this is multivariate. If you univariate. If you go into multivariate, then the entire effect is mainly explained by hematocrit, the effect on the kidney, and you have seen the effect on the heart failure patients. And people now wonder why. Is it volume contraction? We heard about erythropoietin production. There are more genes downstream, such as HIF1 alpha stabilization, the clotogene, sirtuin effect, survival genes are targeted, and maybe this is just the surrogate what explains us what's going on downstream. Here again, how the hematocrit in the EMPA kidney trial changed from 40 to 44. And this is a short-term volume contraction. Plasma volume went down by 7%. Volume contraction, heart failure improvement came in early, but then maybe erythropoietin and HIF1 alpha stabilization in those with low kidney function to a similar extent with normal kidney function. Why so good? I just summarized this, what came out in a recent review. There is a metabolic switch in the kidney as well, which results in the first time increased build-up of energy in glycogen stores in the kidney. The kidney use less glucose and more short-chain free fatty acids, not hydroxybutyrate, free fatty acids they use. There is more hypometabolism, so less absorption, less energy demand, less phosphorylation, oxidative stress, increased cellular longevity is the final readout by generating fewer oxygen species. The hemodynamics I explained, less single nephron hyperfiltration, also single nephron if you have only 30% kidney function, and intraglomerular pressure goes down. So we go from hyperfiltration to hypermetabolism into hypo, less tubular stress, and now nephrologists also create these words. We say summer sleep estivation. This translates into guidelines as well. Here are the KDIGO guidelines 2020, freely available, open access. And here is the fundamental treatment that's standard of care. We all do in our patients. And if we have done standard of care, we go to SGLT2 inhibitors and RAS blockade, evidence level 1A, and this is secondary prevention. So quite clear, and we come in after some lifestyle with metformin and on eye side with SGLT2 inhibitors. EGFR 30 is the deadline, the line for stopping metformin. You reduce the dose, and here you start when it's above 30. This is 2020. DAPA-CKD is 25, and I just heard recently that UK recommendations among the specialties are now start above 15, don't stop until dialysis. So actually you have, in a couple of years, we do not talk about EGFR anymore. We just treat our patients because we have these organ protective treatments in hands. And then if you need additional drug therapy for glycemic control, and for cardiovascular prevention, you go to a GLP-1 receptor agonist or whatever you have in your country available. So I think with these guidelines, and I do not need to summarize again, I think I came to the end of my talk, and thank you for the attention.